So here we have our St. John first response kit. It's very important at the start of every shift to check the contents and make sure they line up with the manifest. Right, up here we have our diagnostic vitals equipment. We have a stethoscope, blood pressure cuffs, one for adults and one for pediatrics, blood glucose kit, we have a tympanic thermometer, and we have a pupil torch. And we also have some shears in there, that's cool. Here we have personal protective equipment, so you should be able to find masks, glasses, biohazard bags in there. And here we have hemorrhage management equipment, so we have tourniquets, we have saline for irrigation, we have bandages and gauzes of various different sizes, and we have transport tape. Here we have anesthetic spray, cervical lanyard and amethyst bags. And here we have hypoglycemia management, so glucagon, glucose in solution, and we have some oral glucose and a syringe. Awesome, moving into the main compartment now. At the top in this pocket we have pain management drugs, methoxyfluorine, known as the green whistle. Also have tramadol, Panadol, and ibuprofen in here. Very important at the start of every shift to check the expiry dates on those. And here we have airway management, OPAs, NPAs. There should be a laryngoscope in here, but there isn't. There's also some adult McGill forceps in here. Cool. And here we have a nebulizer and some oxygen tubing. In here we have airway medication, adrenaline, salbutamol, and ipratropium. Important to check the expiry dates on those as well. Here in the main section we have a sharps container, we have a big bag of saline, there should be a slippery Sam and a towel in here. We have cardboard splints, a neck brace, we also have our LMAs, BVM for pediatrics, BVM for adults. Make sure to have 2 different size masks in there. And we also finally have an IV roll. So here I have my LSU, Laerdale suction unit. This is the unit, it's the Bemis canister, this is the vacuum tubing, it's the patient's tubing, and this is the rigid catheter. Alright, to test it, I am going to hold down the test button. I'm going to make sure it's off first. I'm going to hold down the test button, turn it up the knob all the way to the maximum. Once it reaches the second button up, I obscure it, and just hold it like that until it falls silent. And eventually, it should do that. Cool, that's how you know it works. Awesome. Can you stop it?
Go for it.
So this is indicated when a patient has a foreign body in their oropharynx, such as fluid or vomitus, that we need to extract with the suction. Okay, so the patient should be lying lateral on their side, preferably in the recovery position. So, yep. I'm going to turn it on. Very important to only go as far as you can see into the mouth. Only have a suction on the way out, and suction in circular motions for no more than 10 seconds. So, like that. Okay, cool. Complications of a suction unit include induced vomiting. You can induce bradycardia by stimulating the vagal nerve. You can get... Sorry, can you stop it? Okay, so complications of suction include you can induce vomiting, induce bradycardia by stimulating the vagal nerve, you can get hypoxia, aspiration, laryngospasm, you can cause soft tissue damage to the mouth. You must always make sure to never use a rigid catheter in a moving vehicle. Okay. So here we have our oxygen cylinder. It's easily identifiable as a white cylinder. It should say oxygen or O2 on it. You'll find it strapped into the wall in the ambulance. It's very important to differentiate it from medical air. Also, it will have a black master valve on the top. Cool. Here is the regulator. Inside you can see we have the Burdock seal. It's very important to check that at the start of every shift because if it's damaged it can cause leaks or worse. Right, to attach the regulator you just match the prongs up into the holes and it should just fit in snugly like an electric plug. Cool. To check the volume, you turn it turn the master valve, see it budged ever so slightly because it's nearly out. To change the flow rate, you adjust this. See, you hear it hissing because it was decompressing just then. I just decompressed it so I can take it off like so. Oh, all right. So to decompress, what you need to do is turn the master valve off, open the flow rate so that the last of the air escapes the regulator. Now I'm going to demonstrate attaching a nasal cannula. So you want your patient flat on their back, have it like this. You place the prongs inside the nose, you hook it behind the ears like so. Oh, there we go. And then you just sort of and you tighten it like this, past the ears. Cool. Alright, now you want a flow rate of 2 to 4 for this. Any more than 4 and you could cause pain or discomfort to your patient. It's important, while the oxygen canister is not being held, to place it lying flat on the side to avoid causing it to fall over and damage itself. Complications, indications of oxygen, actually can you pause it right there? Indications for oxygen include an SpO2 that is less than 94%, respiratory distress, an airway obstruction, they may have shock or traumatic brain injury, decompression illness, carbon monoxide poisoning, or a condition requiring sedation to be administered. Basically, you're supposed to use your best clinical judgment. Cool. Here we have our LifePak monitor. On this side here, we have our defib leads. Unfortunately, we do not have any defib pads available at the moment. In here, we have our cardiac drugs, such as GTN, aspirin, ibuprofen. Very important to check the expiry dates on those. There's also a razor in there for hairy men. We have a test shock box in here. We have our 12 lead, and we have spare electrodes. Oh, and here we have SpO2 measurements. In order to put it onto a patient, I'll basically have it like that. Just put it on comfortably. In here, we have end-tidal CO2. In here, we have our 3 lead, and we should have spare paper in there, but we don't. On the top here, we have blood pressure cuff, one for adult, one for pediatric, and to check the batteries, you lift up that yellow tab under there. You press these buttons. This one's low on battery, so I'll remove it like so. And charge it, presumably. Alright. So now, what I'm going to do, I'm going to turn it on. Excellent. And I'm going to put it into manual mode by pressing energy select. Yes, I want it in manual mode. And now I'm going to select the energy of it, select the energy. So I'm going to put it on 50. While I'm doing this, actually, I'm going to conduct an operational test. So to do that, I press options. I've already done that. Now I scroll down to user test, press it. While I'm waiting for that, I'll just set up the test shock box. Cool. There we go. In a second now. There we go. Cool. So it says user test passed on that. I don't know if you can read it from there, but it does. Now, to charge the shock, you just press the button that says charge. Cool. And then you press the big red button, and it should say energy delivered. Now, if you don't want to deliver the energy, you do the same thing. You charge the energy by pressing charge, except you press that button there to dump the shock. Cool. Finally, to print a rhythm strip, it's not going to display any vitals because I don't have it hooked up to a patient due to lack of electrodes, but there we go. Oops. If I had a patient hooked up to this, that would be displaying their vitals. Cool. To put it into AED mode, you press Analyze.
Analyzing now.
You'll have the defib pads hooked up to a cardiac patient.
No shock advised.
And it will give you CPR
Start
instructions.
CPR.
Cool. To attach the 3-lead, unfortunately I don't have any electrodes with me at the moment, so I can't actually stick it to my body, but what I would do is I just take a look. It says LA for left arm, there's one that says RA for right arm. Put right arm here, left arm here, I keep those there with an electrode. Same with these, right leg here, left leg here. Cool. Now, I'm going to put it into demo mode due to lack of a patient. That means I'm going to have to unplug all these. Cool. Now, to put it into demo mode, I'm going to turn it on. Hold down these. Cool, it says demo mode at the bottom. Now I can just select this to select a lead. See, now I've got a nice even heart rate of 80. Cool. Now I can change the size once I've selected that by going down to size, changing it all the way up to 4. Cool. See, now it's a very big wave. Now to change the volume, you select that heart rate number up there. You select QRS volume. You need to turn it up as much as you desire. Cool. Yep. Cool. So in this video I'm going to do airway management. It's indicated when a patient is suffering from loss of consciousness due to an inability to protect their own airway. When you can hear audible abnormalities such as stridor, or you can see visible abnormalities such as swelling angioedema. Complications include facial trauma, nausea or vomiting, immobilization, obesity, and anatomical differences such as my very own beard. So first I'm going to do the head tilt chin lift. What you do is you just tilt the patient's head back as far as possible. The jaw thrust, you put your thumbs or your palms there and you sort of hook behind the mandible and bring the jaw up as much as possible. The sniffing position, you place a folded towel under the patient's head while they're lying on their back, and you want to have the nose in line with the sternum. And the purpose of all 3 of these is to keep the airway nice and open as possible. And finally, there is the recovery position, in which you have the patient lying lateral on their side. You want their arms and legs locked. Unfortunately, my patient doesn't have arms, but it'd be similar to that. Just to keep them from moving, you want the top of the head pointed towards the floor and the chin pointed towards the sky. Reason for that is it allows liquid to drain out of the airway. Cool, stop there. So an OPA, we use these when a patient has a GCS of less than 8, a motor score of less than 6, or they are producing incomprehensible sounds of pain. We measure it by taking from the corner of the mouth to the end of the mandible, like so. As you can see, I've already chosen the correct length. You have it sort of hooked up towards the top of the mouth to insert it, and then about halfway in, you twist it around like so. Complications of this include the size. It could be too big or too small. You can cause soft tissue damage to the roof of the mouth. You could have a patient with a jaw tone that interferes with it, such as trismus. You can also cause induced vomiting. Contraindications include a intact gag reflex and facial trauma. So now we're going on to an NPA, the nasopharyngeal airway. We only ever use these, well, we use these when we need to intubate a patient, but we can't use an OPA for some reason, such as facial trauma. Cool, so to measure it, you measure from the nostril to the mandible, same as the OPA, except with the nostril instead of the mouth. You lubricate it. This lube has just run out. Let's just pretend I lubricated that. And you choose the largest nostril. If you meet resistance, you can just sort of twist it around or use the other nostril perhaps. Cool, and then we have a nasal airway. Now, complications include nosebleeds or polyps. Contraindications include a base of skull fracture. So here we have our bag valve mask. This is the chamber. Here is the oxygen reservoir. Normally it goes here, but I'm just going to check for leaks real quickly by inflating it using the chamber as such. So here's the PEEP valve. It's contraindicated in pneumothorax and cardiac arrest. Here is the filter. Alright, here's the mask itself. It's always good. Make sure to check you have 2 different sizes at the start of every shift. And finally, here's the oxygen tubing. So, first I'm going to go through a CE grip. That involves having one hand, thumb and forefinger over the mask, holding it to the face. Make sure you've got a nice seal. The rest of your fingers under the chin. Double-handed grip is basically doing the same thing but with both hands, and you want a partner to operate the chamber for you. Ventilation rates for cardiac arrest patients in children and adults with respiratory causes such as drowning. It's 2 ventilations every 15 compressions. For normal cardiac arrest adults, it's 2 ventilations every 30 compressions, and for non-cardiac arrest patients, you adjust your ventilations according to the patient's needs. Rule 3s, no more than 3 fingers, squeezing 1/3 of the volume for more than 3 seconds. So, cool, you can see nice lung inflation there. Right. Complications include gastric inflation, barotrauma, or you could get hyperinflation of the lungs. Predictor of difficulty, you can do a Mohs assessment, so the mask seal, my beard could get in the way, for example. Obesity, obstruction for O. A is age, N is no teeth or neck mobility, and S is for stiffness or snores.